Let's go ahead and get started here. Okay. Good evening, everybody. Thank you all for being here. While we give a few people more time to get logged in here, let's go ahead and just do a quick introduction. Let me make sure we are recording this. Okay. All right. So we're going to give a few more people to get signed on here. But if you've been following me for a little while, you know that I am a board certified diagnostic radiologist. My name is Dr. Todd Berry. I've got my fellowship training in musculoskeletal imaging and intervention, and I trained at a level 1 trauma center. So I've seen all kinds of crazy high-speed car accidents, gunshot wounds, assaults, you name it, I've seen it. One thing you may not know about me is I'm actually married to an attorney, and she's not just any attorney. She actually, her specialty is personal injury and medical malpractice. So you can imagine that conversations at our dinner table can be very interesting, and oftentimes they are. So between what I see as a diagnostic radiologist, what she tells me about in her practice, and things that I get consulted on regularly as an expert witness, I get a lot of good insight on a lot of really interesting cases, a lot of complicated cases, difficult cases, and things that can kind of go wrong, and why they end up into lawsuits and litigation. And, you know, hopefully we can learn from those sorts of things to prevent future errors, right? And that's why we're here tonight. So I'm going to go through a lot of those things with some interesting cases I've got planned for you tonight. So I hope you're going to enjoy those. I got into radiology because I really love anatomy, and I love pathology, and I also love telling stories. And a quick story about our kids. We've got 4 of them, and thankfully Shelly has them out doing all their extracurricular activities tonight, because otherwise they'd be the first ones in here wanting to know what kind of bones I'm showing that are broken and what foreign bodies are lodged, who knows where. They love kind of all this stuff. So they're always asking about things that I see whenever I get home from work, or if I'm working an evening call shift or something like that. They say, you know, a picture is worth 1,000 words, right? So with radiology, we see a lot of pictures, so we can tell a lot of stories. And what the really cool thing is, the stories that I can tell from being a radiologist and what I see on the images really complements the stories that you know as a referring clinician. And when you put those stories together, it often provides the critical link between your patient's chief complaint and what the final diagnosis is. So we work together as a team, you know, beautiful things happen, patients get optimal patient care, and everything goes smoothly. And I think that's what our whole goal is in the healthcare system. So I'm going to show you some really interesting cases here tonight. And with that, let's go ahead and get started. So let me see if I can share my screen here. Okay, so radiology tales from the ED, 12 critical findings you don't want to miss. So the first bonus of tonight is clinical correlations already. So I've gone through, and you're going to see a lot of interesting clinical cases, and the x-rays and CT images that kind of go along with those. So a few disclosures, no relevant financial disclosures. My business in this course is accredited through the American Academy of Family Physicians, and we're going to be talking about some legal things here tonight, but I am not an attorney. I'm not qualified to give you any legal advice, so I'm not going to be giving you any legal advice, and nothing that I talk about in any of these discussions, you know, obviously this does not replace a formal radiology residency program, and I do not endorse final interpretations by, you know, non-radiologists. So just keep those things in mind as we're going through. Kind of the ground rules for tonight. I'm going to go through and show you some cases. Everybody's going to be muted. There will be some time at the end to ask some questions. So make sure you stick around, and we'll go through those. I'm going to show you a number of high yield, kind of don't miss cases and some good calls. And then I'll talk a little bit about a new course that I have launching this week, and kind of give you some information about that, answer any questions about those. And if you stick around to the very end, you'll get a free CME certificate sent to you and a special bonus offer. One thing that I'll say, obviously radiology is a very visual field. So I would encourage you to kind of, put down your phone and sit down and just kind of relax and make sure your eyes are on the screen so that you can get really the most value out of this presentation here tonight. So we kind of went through this stuff already about me. And let me just go through and kind of first tell you what this course is, or what this lecture is not. So like I said, it's not legal advice. Zebras in medicine. So a lot of zebras are, very interesting. So rare cases, they can be very interesting to talk about and to see and kind of show around when they pop up. But I'm really focused on what's clinically relevant to you, what's going to be showing up in your clinic or in the emergency department where you're working and that sort of thing to help you get the most value out of some of these cases. All right. And then along the same lines, I'm not going to show you, there's a lot of incidental findings that can be seen on x-rays and CT scans and that sort of thing. And the ones that are not clinically irrelevant, they're not going to have a clinical impact. So we're not really too worried about those because those sorts of things aren't going to affect patient outcome. Okay, so we're going to focus on high yield cases tonight. So high acuity, there's going to be a lot of, a lot of these cases were, presented to the trauma, into the emergency department. And a lot of these things are pretty common. So you'll be seeing some of these things in your practice. And the thing about them, if they're missed, they can be very subtle, and if they're missed, they can have high complication, which leads to high morbidity, high mortality. And whenever there's high complication potential, unfortunately, there can be high litigation potential, right? So the first story I want to tell you about here tonight is actually not, it's not a clinical case. This is actually a case that I was consulted on for a criminal case. And it starts in this this house back here. It's kind of behind this house down this driveway, where this gentleman, he didn't know, but he was actually being surveilled for over a year for child pornography, possession and distribution. And actually, I didn't know it when I was consulted on this case, but a good friend of ours, we had actually gone out to dinner with him before this all happened. And he would tell us about how stressful these situations can be, because when they're raiding these individuals after these long surveillances, they're often cornered, they're desperate, they kind of have nothing to lose. So they'll basically do anything. And this guy was actually armed with a high power rifle. And I got consulted because he ended up shooting one of the officers a couple of times. And their defense was that, you can see the x-rays here, he has all kinds of bullet shrapnel lodged in his shoulder, but he had no exit wound. He had a couple of entry wounds, but he had no exit wound. So their defense was saying basically that, you can't prove that these are our bullets. And they basically said these bullets came from your own sort of friendly fire, So I got consulted to kind of analyze the bullets and the trajectory, the paths of the bullets. And, to make a long story short, so here I am in court testifying. I had a mannequin that I got to go up and kind of, show where the trajectory was based on the pattern of injury. He had a lot of fractures. He had a lot of soft tissue, vascular injuries, neurologic injuries, and that sort of thing. And, based on the CTs that you see here and some of these other images, you could come up and show not only were there, two bullet tracks, but the pattern of the injuries kind of showed the trajectories, which were not consistent with where his fellow officers were, but they were in fact consistent with where he was in the room when the officer entered. So pretty interesting stuff. And, so radiology is not always, just clinical, but it can have an impact in more than one way as well. And he was found guilty on capital murder and child pornography charges, got sentenced to life and something like 1,200 years on top of that, like a little over 1,200 years. So something crazy. So, and before we get into the rest of the cases, so why is it important for you as a referring provider to know anything about radiology? Well, number one thing, direct patient care. So educating your patients, your own education, and really making sure that you are ordering the best exam for the study and the diagnosis that you're trying to find. So knowing the appropriateness of an exam can help to prevent unnecessary testing, making sure that you're getting the appropriate follow-up. And we'll talk about follow-up, here in just a little bit, and what can happen when the follow-up is not followed. And then also just knowing different exam limitations. And we'll go through some of these things and some of the cases here in just a little bit. How many of you are practicing in a rural area, or you're working overnights in the ER? There's not always a radiologist immediately available to bounce questions off of or to render a final report. So there's a few, some critical things that you want to be able to pick up on your own, and then know when you need to say, hey, this looks funny, let me follow up and try to get a hold of the radiologist when I can. We'll kind of go through focused versus systematic approaches to looking at different exams. And some of you might be in private practice. You may not have a radiologist, kind of easily accessible. Some of you might be doing independent rounding. So again, you might be looking at things on your own, at least preliminarily, trying to kind of understand and making medical decisions based on that stuff. And knowing some of these things, knowing the limitations and some of the artifacts that we see commonly can help you to understand when it's appropriate to call the radiologist, question, hey, does this result on the report, does it make sense? What else can I give you to kind of help make a better differential diagnosis out of this and kind of get more specific, instead of just always taking things at face value. So all these things, you're going to add value to your practice, you're going to add value to your patient. And obviously, if you're participating in multidisciplinary conferences, radiology is often involved with those. So it can help you to have an edge when you're looking at that and kind of knowing what's going on. And then obviously with all these things, if everything goes good, you'll reduce patient complications and litigation potential. So there's a lot of trends, a lot of things in medicine are changing. There's a lot of advanced practitioners going into radiology. So what are the errors, or the three most common mistakes that non-radiologists make when looking at exams? So number one, satisfaction of search. So this is when you order, say, a chest X-ray, and your patient fell down, and they hurt, right here. So they point to right there. You look there, and you see a rib fracture. You're like, great, rib fracture is done. We can treat his pain. But what you might not see is maybe the subtle pneumothorax. Okay, so satisfaction of search is when you make one finding, and then you stop looking for anything else. Focused approach based on your exam. So kind of the same thing, your patient falls down, they hurt their wrist, and they point to, one finger, and they're, they say it hurts here. So you look there, and you maybe see a fracture, maybe you don't, but then you miss the other fracture. So you kind of get that tunnel vision, and you stop looking for anything else. And then, viewing on the fly. So, a lot of times if you're, say, in the emergency department, you've got obviously lots of distractions, right? I mean, radiologists, we have distractions as well. You're probably not viewing it on an actual diagnostic monitor. You're viewing things on, maybe it's just a small computer screen. And so when you're getting distracted, you might forget to look at something else, and it's very easy to miss something subtle. So what can we do? What's the number one way to prevent this? Well, what do we spend years in our residency doing? And that's basically developing a systematic search pattern, where we do it over and over again. We're disciplined to always follow the same routine. It can be very boring when you're kind of doing the same thing over and over again, just with anything, right? But being disciplined, following a systematic approach, if you say you're looking at, if I'm looking at a CT scan and I get stuck looking at the kidneys, and then I get a phone call or somebody wants to come in and look at something, I know I can go back there, stop looking at the kidneys. I know what else I have to still look at. So following a systematic approach and understanding where the blind spots are on certain exams and where your own personal blind spots are is very important. Now, other common error types that you might see, just failure to perceive something. Again, having a systematic approach and making sure that you're specifically looking at blind spots is going to let you perceive those things better. You can have knowledge-based errors. And, again, if you're tired, distracted, all those things are going to affect your ability to interpret. And so what are the two of the most common reasons that lawsuits are filed? Well, most lawsuits are obviously going to have some sort of misdiagnosis or delay in diagnosis. And that's going to turn into a complication. So for it to be an actual malpractice sort of thing, not only does the finding have to be, or the diagnosis have to be delayed or missed, it actually has to have a clinically significant complication. The other thing is documentation. If you were ever going to be named in a lawsuit, or if I'm being consulted on a lawsuit, the first thing that the attorney is going to do, they're going to request the records. They're going to request the images, the reports, the clinical notes, all those things. So you want them to be accurate, you want them to be complete, and you also want to make sure that they are consistent with what you have told your patient. So what you are communicating to your patient is the same thing that you're documenting, okay? And the number one thing to kind of mitigate risk when things do go wrong, like I said, I'm not an attorney, but I think most will tell you communication. And this not only includes communicating with the patient, but also between providers. As radiologists, the majority of our communication is through our reports. So making sure that you're following up with the reports. And, as radiologists, we need to, if there's something unexpected, we typically will call, or if there's something very urgent, we'll call to make sure that those findings are being communicated and recognized so that the appropriate follow-up happens at an appropriate interval. And we're going to go through, again, some cases here in just a few minutes to kind of show what happens when some of that communication breaks down, and again, failing to follow up on recommendations is a big one. So the first case that I want to show you tonight here, this is not out of the emergency department, obviously. This is a shoulder arthrogram, but it really highlights kind of, how important it is to know what you're ordering and some of the artifacts that might show up on some of the exams that you're ordering, so that if it doesn't always make sense to have that questioning attitude. So this is a 22-year-old, otherwise pretty healthy female volleyball player that had, it's kind of some ongoing shoulder pain. So they were concerned maybe she might have had a labral tear. So they ordered this MRI arthrogram. Now I know you guys, unless you're in ortho, you probably haven't looked at a whole lot of MRIs. But if you see my pointer here, there's this little black dot here that is in the non-dependent portion of the shoulder joint. It's kind of dark on all sequences. And if you do look at shoulder arthrograms frequently, like I do, you will know that this is a very, very typical appearance of a air bubble. Okay, so when you do an arthrogram, you're injecting contrast into the joint with a small needle. You do your best to avoid putting any air in there, but occasionally, a couple of air bubbles get in there. It's not uncommon and not really harmful, but it is important to recognize that. And so this was reported. Now, I can also tell you, after looking at this case retrospectively, besides the fact that the labrum was stone cold normal, this bubble, this artifact, was called a loose body. Okay, so what's the problem with that? So now she's got a reason to have surgery. So they go in to get surgery, and if you'll notice here, again, I know you're not probably used to looking at MRIs, but there's this transection here of the supraspinatus kind of muscle, very odd location, for a tear. Typically, when we see rotator cuff tears, they're kind of down in this region near the insertion. It's a very unusual location. And then if you look at some of the additional images, all this white stuff here, white stuff here on the far end, and then the dark stuff here, that is all fat. So this muscle was completely transected, turned completely atrophic into fat. And so she lost, she had persistent pain. She couldn't use that muscle anymore, weakness, limited range of motion, all those things, could have been prevented, based on, the interpretation. And then, if the, a little bit more of a questioning attitude, does this result, actually make sense, for you to have a loose body, in an otherwise normal, healthy, young patient, had no cartilage damage, things like that. So when we're doing these techniques, you want to have a good technique to avoid introducing air, and artifacts like that as much as possible. But it's also important to know what some of the common pitfalls are and what might show up, when you're ordering whatever the exam is, whether it's a CT, whether it's an MRI, and then coming up with a differential that if you're unsure, at least say you're unsure, but it could be this or this, Okay, so our next case, this is a 5-year-old that that fell on a trampoline. So I'll give you a second just to look at these images. So we've got 3 views from an elbow series, and you may notice that there's a fracture. So she fractured her ulna. It's comminuted, mildly displaced. And if you kind of just stop looking there, you're going to miss the fact that this radial head is displaced. So there's a radiocapitellar line here. It is laterally and anteriorly displaced and dislocated. So this is a radial head dislocation and ulnar fracture. So very important that dislocation is picked up. So this was noted. This was identified. It was a good call. And this is called a Montesia fracture. Basically, when you have an ulnar shaft fracture in the radial head, the fracture is usually obvious, but the radial head dislocation can be very, very subtle sometimes. So it's important to recognize that this is a possibility and really pay special attention to be sure, especially if you're looking at kids, because if it's missed, it can have very serious complications and medical legal, ramifications, really high morbidity and longer recovery, and limited use out of that elbow that can last a very, very long time. So this can happen from fall on an outstretched hand. There's a classification system that you don't really need to memorize. It's more important just to recognize when the finding happens and then be able to describe the pattern of injury. It's typically treated surgically. And one thing to keep in mind too with kids and adults, but if you're imaging the forearm, there's this ring mechanism. So you think about like rings in the body. So like the pelvis is a good example, but like of a bony pelvis, bony rings that form. And it's very difficult to fracture just one part of a ring. Think about trying to break a pretzel apart. You can't really break one portion of it without breaking the other portion. So the forearm, the lower leg with like the radius and the ulna, the tibia and the fibula, it's not a complete bony ring, but those ligamentous attachments transmit the forces, and you can have more than one fracture proximally and distally because of that. The other thing to keep in mind, especially if you're looking at kids and x-rays, is that normal ossification centers can mimic fractures quite a bit. So I would recommend having some version of this book, Keats. This is, I think, the version number 1. I think they're probably up to like 12 or 13 by now. But this goes over all the different normal variants, and it can be very, very helpful, particularly if you're not used to looking at pediatric musculoskeletal x-rays. So here's a companion case, just another example. So you'll see this radius and ulna are dislocated posteriorly. There's a big joint effusion. You'll see this posterior fat pad, sale sign. And if you are not careful and don't do a good physical exam or recognize that there can be additional injuries, you'll miss this impacted distal radius fracture. Okay, so again, just remember that ring mechanism. If you have a forearm fracture in one location, you probably need to get dedicated elbow and wrist x-rays as well. Okay, so case number 3, 25-year-old right-hand dominant male presents, he's a painter, presents with an injury to his non-dominant hand first day on the job. So kind of a leading history here. And this is what it looks like. So he shows up, he's got a little kind of a laceration, a little wound on his finger and some swelling. And he's talking about, he complains of pain. So you get these x-rays. This is actually a case that I had in residency. And you see some foreign material. So some hyperdense material here in the second digit, kind of along that ulnar aspect and volar soft tissues here. The bones otherwise, there's no fractures. The bones otherwise look okay. And so question I have for you, what's the next step in management? So do we just go ahead and discharge them, maybe give them an ice pack and some antibiotics and have them follow up with ortho in a couple of weeks, give them a warm compress and have them follow up with ortho a little bit sooner? Do we need to get immediate surgical consultation or, some sort of just routine wound care? Well, if you never dealt with this before, you may not know. This is actually a surgical emergency, and this is what can happen if you don't recognize what this actually is. So this is a high pressure injection injury with a paint gun. Things can happen with air compressors, grease guns, with mechanics and things, and often the entry wound, as you'll see from these cases from the literature, they're very innocuous. They're very, small little punctate little wounds, but these things inject at extremely high pressures with high PSI, and all that foreign material, that high density stuff, whether it's paint, grease, whatever it is, just tracks along the path of least resistance along the neurovascular bundles, fascial planes, and it can be extremely devastating, basically causing compartment syndrome. So this was recognized by the radiologist and by the ED physicians and treated appropriately. So it's important to recognize this is a surgical emergency. you need to consult orthopedic surgery. All that injected material needs to be removed. Like I said, it follows the path of least resistance, causes a lot of swelling, fluid and increased pressure, all from a very innocuous, kind of benign looking punctate, wound. And basically this can turn into compartment syndrome and lead to amputation, all kinds of complications if it's not recognized. And obviously here, having the clinical history and knowing that is going to be very helpful for you. So, all right, case number 4. So a 45-year-old male, he has a crushing injury to his foot, comes in with pain. And I'll give you a minute to just look at these. This is his initial x-ray on presentation. And give you a close-up here, this one. So not sure if you recognize that as being abnormal or normal. This was called normal. He went home, returned a month later. He came back with persistent pain. Same finding. Hasn't really changed, maybe a little bit, maybe not. Then he came back after being called normal again, and a few months later, and this is what can happen. So this is a Lisfranc fracture dislocation. And oftentimes these can be very, very subtle. If we go back, there's just a subtle little offset between this metatarsal base and this facet here, which should be perfectly aligned. And same thing with the first, they should be perfectly aligned. And I think on the actual images, you could see a tiny little fleck of bone, and that might be the only sign, very subtle sign for this dislocation here. And if this isn't recognized, basically this needs to be surgery, ORIF, and it can cause delay, and basically this can be certainly have litigation potential. Again, it can be very subtle. You can get non-union. This can turn into premature arthritis and just have a lot of morbidity associated with it. A lot of chronic pain. So if you're ever unsure, if you're kind of looking at that and you're not positive, you can do weight-bearing views, which can make that finding stand out, be a little bit more dramatic. You can also consider doing a CT to look for a little avulsion fracture or an MRI if there is high clinical suspicion. There's a few different types that we won't get into, and treatment is basically ORIF, which can be temporary or permanent, and it's typically from some sort of a crushing injury. Okay, case number 5. Your patient presents with abdominal pain, and this is an image from a CT pelvis that was ordered. So keep in mind, this is a CT pelvis. This was not a complete abdomen pelvis. So you'll see that there is diffuse thickening of the bowel wall here. This is a coronal reconstruction that shows this thickening and some stranding around there. And this was called colitis, so inflammation of the colon, and patient was discharged home on antibiotics. So the patient ended up coming back 6 months later and with persistent pain, getting worse, and had a complete abdomen pelvis. And you can see here, looking at the lung bases, tons of pulmonary mets, pulmonary nodules. The liver has tons of liver metastases, and then this mass is obviously growing. They've got kind of overhanging edges, very mass-like here. So this ended up being a colon cancer that was kind of misdiagnosed. It looked like just a kind of run-of-the-mill colitis. But nonetheless, we don't know what the lung bases and the liver looked like on that initial presentation, but pretty reasonable to assume that it could have been normal or very much less conspicuous there. So some take-home points to this, ordering a CT pelvis versus an abdomen pelvis. Typically, CT pelvis is ordered if it's something very specific, right? So like trauma to the pelvis, or you have a superficial wound, something that you're pretty certain is kind of localized to the pelvis and not affecting. So it's a little bit unusual to just order that, if you kind of have vague abdominal pain. And perhaps if the abdomen pelvis was ordered, there might have been some of those other findings that might have led you to kind of conclude that this is more than just the colitis, and that the patient needed some more urgent, additional follow-up other than just kind of routine, follow-up or none at all. Using the sagittals and coronals, on that first one, maybe perhaps look a little bit more mass-like, to expand that differential, and getting follow-up, making sure these patients aren't lost to follow-up so that they get the appropriate treatment, and get a colonoscopy if there's any question of anything else going on, and kind of expanding that differential. The next case, so this was an abdominal pain and chest x-ray from the acute series. So the chest, and then there was a couple of other abdominal x-rays that I'm not showing. And I'll give you just a second look at this. This is from 2015. And if you notice, there's this small nodule here, incidentally noted in the left upper lobe. Now, good thing was that this was mentioned, and follow-up CT was recommended. However, it was sort of a relatively unexpected finding. There was no phone call, and there was no follow-up by the ordering provider on the report. So this kind of dropped through the cracks and fell through the cracks, and the patient came back with a cough 4 years later. You can see what that turned into. So huge mass, huge lung cancer that was just kind of brewing there for 4 years, and had the initial recommendations that were made. The finding was made. If it was followed up, like it was recommended, this thing could have been taken care of much sooner, easier, and with a lot less morbidity associated with it. So again, the communication is key. Case number 7, another chest x-ray here. So we're going to go with the theme for a little bit. I'll give you a minute to look at this x-ray. So we've got the one on the left is from the more recent one from 2019, and the one on the right is from 2012. So you notice anything? So if you're kind of going through your search pattern, and if you know where some common blind spots are, you'll see this mass here in the right apex. So right apex, or the apices in general, are very common blind spots. This patient's got some hyperinflated lungs, emphysematous changes and scarring, and then this mass developed. This is called and got the appropriate follow-up. So this is a good call. You see this big spiculated right apical mass, lung cancer for sure. This is biopsy proven and then treated appropriately. So this is a good call. But again, those apices can be very, very difficult. Now, how about this case? This is a patient, pretty sick. They've got a lot of pulmonary edema. Their lungs are underexpanded, very busy looking chest x-ray. There's lots of little opacities. Their lung volumes are low, kind of heart's a little bit big. He's rotated. There's a lot of these lines over here. And so what finding, might be urgent here? What needs to be done? And if you, kind of notice, there's this lucency over here, and you got this line here that looks a whole lot like a lot of these other lines, I'll admit. And this is called actually as highly suspicious for free air. So the patient got a CT and confirmed large volume of free air. They had this peg tube that was dislodged. And so that was a very, very good call, very tough call, but also highlights some of the pitfalls and some of the blind spots on a chest x-ray. Now, one more chest x-ray here for you. So this is on the place as an inpatient that needed a feeding tube. So the feeding tube was placed on the floor. See the metallic tip here kind of going down to the left upper quadrant. So this is placed, and the preliminary report by the hospital team that looked at this said the feeding tube terminates down in the left upper quadrant. Okay to use, right? Does anybody else have a problem with that? So about an hour or two later, this was read by radiologist. They noticed that while it goes down to below the diaphragm, it's actually following the course of the trachea, left main stem bronchus, terminating left lung base. This has been used, was being used kind of in that interval of time, and they called, repositioned it, and then the next X-ray, just huge pulmonary edema, probably some pulmonary hemorrhage, very bad, morbidity associated with feeding down the bronchus, as you might imagine. So obviously something that needs to be recognized. And if you're happen to be looking at these and you see something that looks kind of funny, that'd be a time you want to call the radiologist. Hey, this looks funny to me. What do you think? So paying attention to those lines and tubes and kind of following along their course and understanding what is normal anatomy, really is important to recognize. Let's see. Oh, computer's frozen here. Okay, here we go. We're back. All right, so failure to diagnose and to recognize that finding. All right, so again, so what are the final checklists, pearls for, your systematic approach of a chest X-ray? So, you want to have a systematic approach, but there's basically four common blind spots on a chest X-ray that you should be looking at before you're done looking at it, okay, on all of them. So the apices is a big one. You can really have some masses and things that can be fairly subtle. Again, pneumothoraces and that sort of thing can hide out there. The hyla, that's another big one. It can be very difficult to spot, masses or adenopathy and other things, in the hyla, but you always want to give it a second look. And then, of course, the diaphragm, like we saw, you can have critical findings below the diaphragm that that can be very difficult if you're not specifically looking at them, okay? And then obviously extrapulmonary diseases, the chest wall, the ribs, looking for fractures. Most of the time you're getting a chest X-ray, you're focused on the lungs, maybe the heart, but you want to make sure that you're paying attention to the chest wall and kind of all those ancillary things. And, obviously if the patient has any tubes or other foreign bodies, those have to be a part of your search pattern as well. And always, if make sure you're following up with the final report, or if you see something that looks funny, doesn't add up, you're calling the radiologist, kind of going over and asking those questions. Okay. So next case, patient presents with kind of mild thoracic back pain. So you get this X-ray here and got two views. I'll give you a second to look at it. You notice that there's some degenerative changes, disc space narrowing, some small osteophytes, and again, kind of the same sort of blind spot, if you're not doing a systematic approach and kind of same thing as on the chest X-ray here in the hilum, you'll see this big mass. It's hard to really find on the lateral. It's probably kind of projecting over the spine here in the mid spine. This was recognized, thankfully, and CT was ordered and shows and confirms this large right lower lobe mass, this big lung cancer that was treated. Okay, so again, just if you're looking at spines, kind of like the chest, where you don't want to forget the extrapulmonary findings with the spine, don't forget to look at the lungs, kind of the opposite, and it all goes back to having that systematic approach and kind of knowing where the blind spots are and kind of looking at some of the things that can be potentially incidental and significant incidental findings. So, all right, so this next case is a very common thing that's going to come in the emergency department, or outpatient clinics. This is an older guy who had hip pain after a fall. So you got 3 X-rays here. I'll give you a second to look at them. Kind of a tough case, sort of subtle, easier to see on the diagnostic images. But there's a subtle fracture here of the greater tuberosity. So this is called, probable fracture, probable greater tuberosity fracture. Recommend getting a CT scan for confirmation. So the CT scan was ordered and appropriately called a greater trochanteric fracture. So this was called, and the recommendation for this was to get an MRI because it's a known common association. If there's a what looks like an isolated greater trochanteric fracture, to have an occult intertrochanteric extension that you may not see on X-ray or with CT. So the MRI was ordered appropriately. However, the patient was discharged prior to the final interpretation. There was a preliminary note that said greater trochanteric fracture, no definite intertrochanteric fracture, and then final report pending, follow up with discharge in follow up with orthopedic in 1 week and discharge. So then the final report came out. Radiologist recognized that this was actually an occult intertrochanteric fracture, non-displaced. You can see the edema here on this fluid sensitive sequence. And then on this T1, you can see this kind of curvilinear fracture line extending down into the intertrochanteric region. So what happened? Well, there was no phone call, there's no communication, and the orthopedic team didn't follow up on this report after the patient was discharged. So the patient comes back 3 days later and it looks like this. So they've got this displaced, comminuted, angulated, fracture, and obviously much more urgent and complicated case at this point. So we want to avoid that, and certainly delaying diagnosis, failure to communicate, follow up, all those sorts of things that you want to make sure that you're staying on top of. So case pearls, elderly patient with traumatic hip pain, very common. These people have low bone mineral density. Osteopenia can make looking for fine, subtle non-displaced fractures very difficult. So, you have to look very carefully, and you have to have a high clinical suspicion and know when more advanced imaging is indicated. And if you do, if the patient's got, painful weight bearing and, the x-ray looks negative, CT is going to be the first step. It's about 85% sensitive. So if you still have a very high clinical suspicion, the CT is negative, or, shows a finding like this with that trochanteric fracture, MRI will be the next step. And, of course, make sure you're following up on the studies, you're looking at those reports and making sure that if there's any sort of recommendations or incidental findings that need follow-up, you're ordering those. And make sure you know that the associations and the limitations, of the exams that you're ordering. And in this case, like I said, there's that high association of having an occult intertrochanteric fracture. So, all right, the last case, or last two cases are actually presented together. These were sisters that came in, young, they're 7 and 13 ages. And this is a 7-year-old. So she came in, had a head injury after a rollover accident. I'll give you a second look there. And, fairly subtle. If you change the window a little bit, might help you out. And you see this extraaxial kind of elliptical shape fluid collection here. So this is a small epidural hematoma. And if you put it on bone windows, you'll see that she actually had a skull fracture there and some soft tissue swelling, contusion overlying it. Pretty subtle and, pretty small, but very important. This is the type of thing that if not treated or not monitored very closely, very quickly can become very big and very catastrophic if it's not recognized and treated appropriately. Okay, the next, this is her sister. So she came in, she also had pain and, head pain, and she actually had a very small, skull fracture, very subtle non-displaced skull fracture going down to the skull base. And that's also another blind spot. The skull base, the posterior fossa on a head CT can be very subtle. There can be a lot of artifact, a lot of streak artifact from beam hardening, from those bones. So looking in those bony windows is good. So these were both recognized, thankfully, and they got the appropriate treatment. But, these brain, hemorrhages can be very subtle. So it's important to know concepts of window and leveling so that they can be treated appropriately and recognized. Bone windows, blood windows, actual brain windows, all those sorts of things. So, when you're looking for signs of stroke, hemorrhage, other things, masses and that sort of thing. Looking at the sagittal and coronal recons is important. Understanding the concepts of coup and contra coup injuries, and then also just knowing about where common blind spots are on head CTs. Okay, so that's all the cases I have for you. So a little summary of kind of some radiology pearls for you. Old studies are better than brains, right? So if we have old studies, if you can compare something to something prior, that can really help you to understand if it's changing, if it's stable, and kind of lean you one way if something needs to be acted on more urgently or not. If it's changing very quickly, then you're going to want to act on it more quickly. If something's been stable for years, then it's probably not anything aggressive or too urgent, and that can really help you. One of the hardest things in radiology is knowing what's normal. We talked about with the kids, those normal ossification centers. There's a lot of normal variation, and understanding what's normal and kind of things that can mimic disease is very important because you want to be able to limit unnecessary testing. And, you're not wanting to order more scans than what your patients need. It costs, more money, more time, more anxiety, more radiation exposure, a lot of things. So you want to make sure you're doing what's appropriate. You want to know what's common blind spots, how to spot, certain areas on the exam, and then, communication, documentation, follow up, on those exams. They're all keys to make sure that, your patients are getting the proper care that we all want to deliver to them. Okay, so that's it for the presentation. I want to transition now and just kind of tell you a little bit about the radiology onboarding kind of course that is launching this week, and then we'll get into some Q&A before we finish. So the diagnostic, it's kind of 3 courses in one. You've got a diagnostic radiology primer for non-radiologists. So this is specifically made for referring clinicians or maybe advanced practitioners that are interested in radiology, but other physicians that have not had radiology exposure in their residency programs, or any other much exposure in your general education program. So this course is going to go through based on a patient-centered approach, and we're going to basically go through all the keys of diagnostic radiology. So X-rays, radiation exposure, contrast usage, appropriateness criteria, knowing normal anatomy on basic chest X-rays, going through basic findings, critical findings on different exams that you're going to commonly order, detailed approach to CT exams and knowing the normal anatomy so that you can bring those up and go over those with your colleagues, with your patients, and educate them to give you guys all a better understanding of the disease processes that you're managing, and providing optimal care, and really just adding that value to your team, that you're other clinicians that you're working with, and to the patients that you're treating. Okay, and then the next part of it is the musculoskeletal and spine procedural skills modules. So I'm going to take you through the technique of doing different fluoroscopic guided musculoskeletal joint injections, aspirations, arthrograms, and that sort of thing. Understanding the indications, when to order these, if you're ordering them, what the limitations are, how your patients should be prepared for them, or any sort of contraindications, and that sort of thing. And then, same with spine, epidural steroid injections, pain injections, that sort of thing. Then there's going to be a fluoroscopic, GI fluoroscopic exams module. Going through, there's a lot of barium studies, gastrograph and water soluble, contrast studies that patients are ordered. So understanding how those exams are performed, understanding the technique and the indications for those, patient preparation, kind of being able to go over those findings with them. And we're going to go through, kind of all the most common ones, that you have there. So that's all going to be included, so the diagnostic part of it is, $899 value. The musculoskeletal procedural skills module is a $499 value. The GI exams module is going to be a $499 value. You're also going to get access to any sort of bonus webinars that I do in the future. Monthly emails. I'm very responsive to email. And if you're not already part of the private Facebook group, Radiology Skills for the Non-Radiologist, I would encourage you to do that, to sign up and join that. I post cases in there regularly with case discussions, and I try to keep those very clinically relevant to you. And I'm always looking for feedback for different types of cases that you guys are interested in, or if you have questions about something that comes across, you can certainly post that in the group, and I'll be happy to answer for you and get input from other members in the group as well. So a good value there. So over a $1,900 value for everything. And it comes with 30 prescribed credits from the American Academy of Family Physicians. So, that's enough credits to get, most people's, kind of yearly total. So a lot of good value there. And then just learning this information and understanding the diagnostic concepts and skills to make you a better clinician, and just really optimizing patient care, making sure that we're doing things appropriately, and kind of eliminating risks and being more efficient with the way that we're ordering skills. That's kind of the reason why I did this. And I kind of distilled all the stuff that I get asked most commonly from when I'm working and I'm getting calls from the ED or from the floor, from outpatients, clinics, all the questions that I get most commonly and the things that I see that can be improved upon is kind of what I focus on, in this course. So again, just to kind of recap, the total course value is over 1,900. It's regularly priced at $799. And with the course launch this week, if you go to the checkout at this URL here, https://medicalexpertsolutions.com, it'll give you more information about the course. And if you check out, make sure you put RAD 100 and you'll get $100 off this week. And it's only $699. And it'll come with all that. You also, like I said, you'll have access to that Facebook community, lifetime access. And I'll be happy to have you in there. So if there's any, let me stop sharing the screen here for a second and see if I can, if you guys have any, I'm going to unmute, or if you have any questions, you can try to unmute yourself, or you can put them in the chat box and I'll be happy to answer anything that anybody has about the course, about any of the cases that I showed. Just let me know. Lucia, thank you very much. I'm glad you guys enjoyed the presentation. You're very, very welcome. While I'm just kind of waiting, I'll give you guys a chance to ask anything. I'll just kind of go through some of the FAQs that people commonly ask. One thing that people, that I get asked, or that has kind of come up is, does this qualify you for, rendering final interpretation? So this is not a radiology residency. This is not, this does not replace a radiologist, going through this course. Okay, that's not my intention. I don't think that's what any of y'all's intention is either. You don't want that liability, trust me. But this is going to make you more competent in knowing how to order what needs to be done most appropriately, and then communicating with your patients, explaining to them risk with exams, why they need the exams, what might follow up with the exams. And that sort of thing. So let me get a couple of y'all's questions. How do you recommend to document communication with the radiologist from your perspective as a radiologist? So good question. So, so from my point of view, when I am documenting, I am putting who I talk to and when I talk to in the report. So I would recommend you doing the same thing in the patient's chart. The patient that we're talking about, I would just put a note either within their most recent clinic note, or just make a new note that just says, documentation, telephone, phone call with Dr. Berry or whoever. This finding was communicated, at this time, and this is what the plan is going to be from here on. Okay, so that's what I would do with that. Let's see. Next question is, when you say the $100 off ends this week, do you mean tomorrow, since it's Friday, or when is the date for that? So it's going to, the $100 is going to, the $100 off is going to be through October 2nd, so Sunday. Sunday at midnight is kind of the deadline. If you go again, let me put the so it's https://medicalexpertsolutions.com. There's a countdown timer on there. And that basically ends Monday at midnight Eastern time. So let's see, you've been mentioned advanced practice providers. I'm a new PA in need of imaging instruction. How appropriate is this course for a new PA? Honestly, this is like designed for new grads. The majority of the students that have already gone through it are new, new or relatively new. Some do have, more years of experience, and it's also beneficial to them. But, in my experience talking to different PAs, nurse practitioners, and other physicians out of training, unless if you really specifically look for radiology training, there's not a whole lot, unless you're in a radiology residency. So this is kind of filling in the gaps. And what I think is most important for you as a referring provider to know about radiology, so that you are more confident when you're ordering exams or determining which type of exam is going to be the best. So it's very appropriate for new grads and really practitioners of all levels. If you have not had a lot of experience or a lot of exposure to radiology, or working with the radiology in a radiology department, it's going to be very beneficial for you. This course has been used by radiology practices nationwide as sort of an onboarding training tool for their new hires going in there, to give them baseline foundation of sort of the basics that they, things that you're expected to know, but were never really taught. That's kind of like everything that's focused on in here. So things that people are going to be wanting you to kind of know and get teed up on, it's going to kind of all be covered up here. And it's going to come with those CME credits too. Let's see. Thank you for the presentation. You're very welcome. Happy to do it. And let's see, do you have any recommendations for resources on systematic approaches to reading common radiographic images? Yes. So radiology onboarding primer for non-radiologists. So this course is designed just for that. I take you through all the most common things: the chest X-rays, abdominal X-rays, musculoskeletal X-rays, head CTs, chest CTs, abdominal CTs, and a lot of cross-sectional correlation with like musculoskeletal imaging, and going through, with like the musculoskeletal section in particular, going through a lot of bone lesions, incidental lesions, and understanding how to evaluate those to characterize them. If it's aggressive, if it's non-aggressive, when it can be followed up, or when it doesn't need to be followed up. So yes, this course it definitely covers all those sorts of things. Sloan, you're very welcome. Glad that you liked it. The time commitment for this course. So very good question. So it is a self-paced course. They are pre-recorded lectures that you can do from anytime, anywhere that you want, at your own pace. So you'll have at least annual access. You'll be able to have downloaded PDF files of the presentations as well that you can have downloaded, and you'll have at least annual access. You'll probably have lifetime access, honestly. If the platform, if I were to ever change platforms, I would just make sure that you had those files that you could just download and have them. So it's a 30 credit hour thing. The videos can be watched, I think in 1.2, 1.5 speed and that sort of thing. But you can basically get through it in a week, and you can do it from anywhere. If you'll get a certificate when you're all done, and if you want to tell me where you did it, I can make a note of that on the certificate for you, and that's not a problem. The live sessions are going to be based on any sort of live webinars I do in the future like this, and I'll try to do those occasionally, and you'll be certainly notified about those, and that wouldn't be any extra charge, obviously. Let's see, I think I got a couple more questions here. Let's just see. The recording of this will be available if anybody had to get off. Let's see. Go through a couple more FAQs that I have before, and we're almost to the very end. Appreciate you guys sticking with me. I'll show you how to get that CME certificate for attending. Again, I'm available through email and through the course private group. So as far as offering support during the course, that is how. And does this course prepare you for any procedures, or do only radiology do radiology PAs or nurse practitioners only do procedures? There's a lot of other services that you may provide, and knowing how to look at some of the imaging can be very helpful from a procedural standpoint as well. Okay, guys. So one other question that comes up: what if I'm in a rural area with a low patient population? will this course help me? And, the answer is yes, because, you're even more likely to be in a situation, overnight where you don't have access to a radiologist and, you're making treatment decisions based on your own preliminary interpretation. So, if you're working in a rural setting without much resources, then, absolutely. So, okay, guys, well, I appreciate your attention. Let me make sure, can everybody see this? Let me put this link here in the comments. This is where you need to go to get, so I just put a link in the comments. If you go to the comment section now, you'll see a link to the to get your CME certificate. You go there, fill out your name, and then you'll get it emailed to you. So I appreciate everybody's attention tonight. That's all I have for you. And I really hope that you got a lot out of that. So thank you, guys. Have a good night. Let's see. Somebody said they're unable to see the link. Just in case, if you can't see it, let me share my screen so make sure you got that. Hold on. Okay. Hopefully you can see this. So I will say it out loud too. So it's https://courses.medicalexpertsolutions.com/webinar-certificate. So check the chat and see if you have it in there. If not, just type that in into your browser and it should get there. And if you've gotten to this point and you still can't figure it out, just shoot me an email, todd@medicalexpertsolutions.com, and I'll help you troubleshoot that. Let me see. Todd@medicalexpertsolutions.com. Thank you very much, Alex, for putting that in. Oh, you know what happened? I just didn't hit enter. There we go. So yes, so when you click this link, so it's in there now. Click that link and fill out the form, and you will get an email. The email may not come right away. Just give it a few minutes. And if you have any trouble, just shoot me an email, and I'll be happy to get that over to you. Great. You're welcome. Okay, guys. All right, you're very welcome, everybody. This was a lot of fun. We'll do it again. And hope you can sign up for the course, and I'll be happy to talk to you more throughout that process once you get into the course, okay? You're very welcome.